meeting. It's not only wonderful, it's also very important that we have already heard a lot of theories, performance, structure, culture, safety, and so on. But now it comes to the practical level about implementation. And as a start is, the first speaker apologizes for not being able to be here. She had to leave early, but she told me that she had recorded her session. Do we have it on video? Okay, go ahead. She's Dr. Grossman from the Technical University of Delft, dealing now in the between the technical side and the medical side with patient safety questions.
Welcome everyone, and first of all my sincerest apologies that I had to leave early to catch my last plane home. I have a necessity to be at home in the evening. I hope I can compensate by recording this presentation to share our work with you anyway. My name is Irene Grossman. I'm a surgeon. I'm also worked as an intensive care specialist, especially during COVID times. And 2.5 years ago, I joined the Center for Safety in Healthcare at the Delft University of Technology. And I want to present some of the work that we have done and what we are looking forward to today. So early this year, I attended the Global Ministerial Summit on Patient Safety, and the WHO identified the 4 key problems concerning improving safety in healthcare, which were poor situational awareness, paucity of meaningful data to actually inform you on what is going wrong in our hospitals, an adverse culture that is resistant to change, and poor leadership. Now, if I take my Dutch approach, I would actually see this. We don't see, and we don't want to see. The answer to that would be, if you don't see, you really need a new pair of glasses. Now, to take this to a more serious area, we actually took this up as an option. We think, from the Delft University of Technology, that we need a change in our perspective, in our view. And that concerns our view on risk appreciation in hospitals. That we have to change our view as healthcare professionals on accident causation and learn from safety science. We have to learn to have a different view on the organization and how responsibility could be divided, and also our view on disease and care. And I want to take you along on each of these topics briefly to demonstrate what we mean by it. Let's, for instance, take our view on risk. In safety science, there is a phenomenon called risk normalization. This can occur when you are in a workplace where there are numerous risks occurring, and as a worker you can get used to taking those risks and underestimate the impact they could have once things go wrong. So as I'm used to in healthcare, we tend to underestimate risks on a daily basis and also learn to ignore the harm that is sometimes caused as being unavoidable. You could call it a cultural deviance in healthcare. So what if we would be able to have a proper risk appreciation based upon data and based upon the knowledge of how to avoid harm? But also in medical decision making, our own profession, what if we consider medical decision making as a key hazard? Can decision theories there help to take better decisions, for instance, on whether or not to perform surgery on a vulnerable patient? And then the view on accident causation. We all know that if we perform an unsafe act, there will be an unsafe outcome. Usually, it is a final act from a doctor or a nurse that causes the unsafe outcome. But the unsafe act never stands alone. There's fatigue involved, there's flawed information, there's fear or uncertainty, and there are process disturbances and many other factors that actually influence the causation of an unsafe act. Also, all these factors influence one another, making it quite a complex system. So, what I was used to in healthcare is that we only looked at the direct causal relationships between what we do and what was the outcome. We do not tend to look at the probabilistic relationships, the factors that influence us, that were not decisive, but actually played a role in the outcome, that could be addressed and improved in a way that we actually improve our work performance. Let's take a view on organization. In understanding that healthcare infrastructure can lead to unsafe care, I have a concrete example. This is Marieke Meinardi. She's a geriatric internal medicine specialist from the Albert Schweitzer Hospital in Dordrecht. And she addresses the wrong bed crisis. This is a phenomenon often occurring in the Netherlands that actually is causing care infarctions. And it refers to vulnerable elderly patients who stay home, cannot stay home any longer due to care problems and multimorbidity. There is no place in nursing homes and there is no proper at-home care, and often these patients end up in the hospital. This leads to both a financial and humanitarian crisis, as hospital admissions are much more expensive than nursing home care. And also, these people are not at the right place, and the care they receive is not the proper care that they deserve. This can go wrong, as in patients that get hospital infections, patients that wander around and fall down, breaking their hips, in the end leading to their death. What if we would actually examine these transfer care systems that should transfer an elderly vulnerable patient to the proper destination, and we would look at the system, both in technical and social elements, that influence whether or not it is possible to have a proper patient transfer system. One of my students in complex systems engineering and management, Britt Wagenaar, actually did exactly so. She made a systems dynamics model of our transfer care system. Those are regional networks that look at the problem of patient transfers between the different destinations. Here you see a combination of a EDF-0 model identifying the proper destinations, and then all the factors that influence whether or not this logistic flow is hampered or improved. What this qualitative method is capable of is identifying leverage points that have a significant impact on the system functioning and performance. One of those is highlighted in the green bubble, which is workload of former caregivers. She found that if former caregivers are not capable of adequately assessing a patient, if it could cause delays, causing hampering of the patient flow. If they did not do the assessments properly, it also caused patients to have complications in the aftercare facility, causing these patients to return to the hospital again, also causing more and more work. So this was a negative feedback loop that occurred again and again, increasing the workload, and with this increased workload, the patient flow decreased even further. Now, it was not possible for us to obtain any quantitative data because this system dynamics model is actually capable of processing quantitative data. And another view in organization is in understanding that the responsibility for safe care is as much on the medical professional as on the organization. We tend to focus, at least in the Netherlands, on what a caretaker did wrong. But what if we would focus on the system? How the system around the person actually influences performance, as I mentioned before. But also the work processes, are they properly designed? Are the electronic health records properly designed? Do they lead to failure or do they not lead to failure? How is it with the human factors engineering in our hospitals? Human factors engineering is not new. System thinking is neither new, but it is seemingly new in healthcare. And it's not often seen that they're properly taken care of in a hospital organization. So why put the blame on a person when often there's a system at fault? So our conclusion was we need a change in perspective, and we need a change towards at least a systems perspective. Just briefly what a system is. A system is actually all elements that are influencing the eventual outcome. They interact, they change. They're social elements, they're technical elements, they're static elements, they're dynamic elements. So it becomes quite a complicated bunch. And what can you do with it with science? Well, quite a lot, actually. At the Delft University of Technology, we have a faculty that's called Technology Policy and Management, who's been doing this type of system science for 30 years. It involves complex systems engineering, decision theory, safety science, multi-actor systems and policy analysis, and a variety of modeling techniques. Because we felt there was a need for this type of science in healthcare, we established an Institute for Health System Science. We did this with 4 scientists, an electronic engineer, a mathematician, a surgeon, and a philosopher. And we recently had the launch of this Institute for Health System Science. What are the challenges we take up? Well, first, safe and sustainable healthcare system, the large challenges that are coming at us at the moment. Responsible innovation and integration of technology in healthcare, and new paradigms in understanding and providing care for health conditions. The last one I didn't mention in my presentation. I could talk for hours about that, but I will leave that for now. Now, what is the challenge of implementing safety and system science in health and care? If you look at this picture, some of you might recognize it as the babelfish. The babelfish is a little fish that's put in your ear in the novel of Douglas Adams, Hitchhiker's Guide to the Galaxy, to actually facilitate the communication, intergalactic communications. Because if you talk a different language, if 2 people are from different worlds and talk different languages, they will not understand from one another what they are talking about, and they will not profit from each other's knowledge. So our mission is to educate. We educate engineers in health and care domain, but we also educate people from health and care in system and safety sciences. We have to study what is possible, what is not possible. We will fail, we will try something that didn't work, but we will at least try. And then comes the problem of not wanting to see. The top 5 reasons to stay a nerd about safety concerns in healthcare are: it is too complex. Well, that is why complex systems engineering has been invented. It's too expensive. Well, in our opinion, it's too expensive to remain unsafe. And this has been proven, not just in health and care, but also in other domains. There's no time, meaning no priority. It's none of my business, it's from the quality and safety department. Well, we argue it is your professional responsibility, and that includes management and board. of the hospital. And then now there's another crisis ongoing. Well, especially now, we should not waste resources on unsafe healthcare. Ultimately, it is all about mental models. If you look at the system thinking model, if you want to change anything, actually what you need to change is the mental model of how we look at things, how we consider things. What we see and what we see actually determines what we can do. In healthcare, there's another complicating factor, that it's involving a lot of emotion. Some of my students in healthcare did their research and encountered quite some emotional responses when questioned about professional autonomy, about standardizations, about any topic that for them is just an objective scientific topic, and for health and care workers it seems to be highly, highly personal and emotional. In our opinion, the road to sustained change is to change thinking habits and a bit of our feeling. Again, we think it should be through education, in connecting these worlds, and sometimes, especially when it is about accident causation and evaluation of calamities, we think governmental regulation needs to call in help from other domains. Thank you for your attention.
Yeah, I believe that was a very interesting and important talk about a system that has to be still has to be developed, but this may be a first step or way how to do it. There are many right thoughts which we should consider in the future. Now it's my pleasure to introduce Dr. Ruth Hecker from Germany. She is a trained anesthesiologist, but now working and mostly working in the German Coalition for Patient Safety. And it's your floor, Dr. Hecker.
Thank you very much. Yeah, hello. Thank you very much for the introduction. Good afternoon. It's a privilege for me to be here today, and I'm delighted that I can talk about a topic that really matters to me and that we all care about: implementing changes. We all want to create environments where patients are safe and feel valued. We all understand that change is not a disruption, but an opportunity for making healthcare safer. We all recognize that every adjustment, no matter how small, can have a profound impact for patient and healthcare staff. However, change can be difficult and hard, and we need a strategy and patience and the right motivation when implementing changes. Now, a short view on the NGO. The EUPSC was founded in 2005 as a registered non-profit association. Anyone interested in patient safety can become a member of the network. Currently, we have about 800 members, and the board has the task of coordinating the project and initiatives. All members of the board work on an honorary basis. EUPSC is founded by membership fees, donations, and third-party funds for projects. There's no regular funding from the government by the Federal Ministry of Health. It only supports our work by funding particular projects and events. What we do, the EUPSC develops and coordinates patient safety activities in the form of recommendations for action, political statements, projects, campaigns, and events. The breakthrough collaborative method was first launched in the mid of 1990s by the Institute of Healthcare Improvement. The change model was created to support healthcare settings, enable breakthrough quality improvement, and reducing costs. The model for improvement requires collaborative teams to ask 3 questions. What are we trying to accomplish? How will we know that a change is improvement? and what changes can we make that we result in improvement. The method is built on several core principles: collaboration, various teams and experts, learning, and adaptability, and data-driven decision-making. And we have heard before that data-driven decision-making is very complex in Germany, and I think in Europe too. It's a big problem. So a breakout series collaborative is a focused improvement project that brings together teams seeking improvement in a focused topic area towards a common aim. And now we have an aim. Sorry. Our topic was harm from sepsis, we heard before. A particular patient safety concern is sepsis. At least 230,000 cases of sepsis per year in Germany, at least 85,000 deaths, most of them preventable, and every 6 minutes a person in Germany dies of sepsis. More people die in hospital from sepsis than from heart attack and strokes combined. So the APS was a little bit stupid, but we wanted action, and we started a campaign launched by the APS together with the partners to do something about preventable death relating to sepsis. The campaign, Germany Recognizes Sepsis, produces materials to raise awareness about the symptoms, diagnosis, treatment, and prevention of sepsis. Our goal of the project, reducing preventable death and harm from sepsis, and the target groups are public and health professionals. The aim of the project is to educate the general population and specific target groups in Germany about the time-critical detection of sepsis symptoms in order to achieve greater awareness of the health risk and thus improve health literacy. Make sepsis recognizable, understandable, and applicable for the population. Establish the issue of sepsis as another central emergency alongside heart attacks and strokes, and increase health literacy in the general population about infections and encourage self-care. The cross-functional team approach, the APS partners and organizations emphasize the value of combining the network with clinical expertise, administrative insight, and patient perspectives. Here you see the partner of the campaign. The Sepsis Dialogue is for the training and further education of medical professionals. Sepsis Stiftung is for the sepsis research. And you see the patients, Deutsche Sepsishilfe. It's supporting groups, perspectives of the people affected. So it's very important to establish effective communication channels, create an environment where open and honest communication is encouraged. This includes regular team meetings, feedback sessions, transparent dialogues, fosters trust, and ensures that everyone is aligned with their goals and objectives. So we had some activities in the campaign: videos, sepsis in long-term care, sepsis checklist and information center, inclusion of sepsis in the first aid curriculum, sepsis knowledge survey, sepsis academy and training materials, quality measurement with billing data. It's very difficult to use them, counseling and support for those affected, and support from famous people affected and politicians, and any more. We had some testing changes. So we started with a humorous approach, which doesn't work. So we create a new website which is user-centered and better for the campaign presentation. The adaptation of regular meetings, we changed from an overall meeting committee with all partners to separate team meetings because it makes communication easier. How we will know that a change is improvement? We are tracking followers and the number of mentions in social media and press. The more widely we spread the information, the more people will learn to recognize sepsis. And we have a representative population survey, which we first started in 2022, and is further surveys planned in 2024 and 26. So these are the first representative population survey by the question, you sometimes hear the term sepsis in connection with illness. Do you at least roughly know what sepsis is? And you see that about 70% roughly know what sepsis is, and 22 or 23% heard the term sepsis before, and I'm hearing the term for the first time about 10%. When you took a different view of the representative population survey, you see sepsis always results from an infection, is about 70% of the population. Sepsis can be caused by infection, pneumonia, kidney or bladder infection. That is, if it's true, it's about 40%. Sepsis is always caused by an infection wound. It's about 65%, and sepsis can result from flu. It's about only 10%. You see that the viral infections are not recognized to become sepsis one time. So we have a lot of challenges to do. Implement changes in small, manageable increments, and knowledge that implementing change in healthcare can be very, very complex. The interdisciplinary collaboration is challenging, very challenging. Education on health topics difficult after pandemic, and the relatively little funding for public relations. So we have more challenges. Coding of sepsis makes it difficult to use reliable data. No quality assurance system for sepsis till today. Today we get the notice that the politics is to bring up a quality assurance system for sepsis, and the political pressure is even hard. Our learnings and recommendations. We need both bottom-up further development and top-down approach. We have to determine clear structures and communication routes, ensure that team members understand their roles and responsibilities, develop a clear communication strategy right from the start, and have regular meetings, promote an open culture. And every time you think it's running now, it's a new block again, somewhere, somehow, sometime. Thank you very much.
Thank you very much, Dr. Hacker, for this impression from maybe a practical example how to do this and what the challenges are. Now, it's my pleasure to introduce Dr. Wermer from the Technical University of Munich. I think we even have worked together in the OR, one on the other side of the blood-brain barrier. And she's a trained surgeon, has now a board-affiliated job as quality manager, and she has studied quality economics, patient data economics, something like this. Maybe we talk about this a little bit later. And now she's talking about the importance of learning from other sectors. Come on.
Thank you very much for the introduction. Thank you a lot for the invitation here to come to European Patient Safety Foundation. And thank you for the great organization for this very important meeting. I apologize that I'm not so good trained in English conversation. Please a little bit happy with if it is necessary. Be sure that patient safety and safety in medicine are my hot topics. It's not only me. We are a team. I'm here in Vienna, but there is a team behind the certificate of TUM, Focus on Patient Safety, actively shaping change. That is what we want to do now in a small part, but it should be spreading out. The team is the TUM University, TUM Medical Education Center. Then we have 2 hospitals, one basic and standard, and the other is supramaximal care with a university hospital. That is where I'm coming from, and Professor Koch also. Then we have a collaboration with Lufthansa Aviation Training, Human Factors Academy, and TUM Institute for Lifelong Learning. And now we have another cooperation for the next course. I will just show you our curriculum, the running course of program, the evaluation of the course, a little summary. And what we can learn together, I think we have to work together. That is what I'm feeling now after all the other talks. The idea was born by a meeting of our president of the Technical University, of our medical director and CIO of the Klinikum Rechts der Isar, and the Minister of State. And they thought it is very important to have an education in safety medicine, safety in healthcare, and in patient safety. And they connected politics, economics, hospitals, and science. And there was we had to take a choice for a HRO that was to have the knowledge and the experience, and it was then the aviation, and the collaboration is with Lufthansa and Martin Egert. I met him in 2019 here in Vienna, and he was then the driver for the collaboration with Lufthansa. You see, we have the certificate. It's a very small part. We started. We have a master program at the TUM University, and at the Technical University Risk and Safety. And the vision is to have a master program in healthcare safety. These are the different points where we are acting. That's the Technical University, the clinic in Straubing, the TUM Campus Straubing. We have a new campus with a focus on sustainability, and the Lufthansa Aviation Training Center at our airport in Munich. The questions are, why HRO? Why collaborating with HRO? Why aviation? What's the difference between aviation and medicine? What connects aviation and medicine? And what can medicine learn from aviation? This is in German. That's from our course, from Cordula Pflaum. And that is what Lufthansa is, the communication of Lufthansa. We already have a safety and error culture. We are far away in medicine. We know that we know nothing. They are humbling. We are sensitive to work processes. We regularly promote our resilience. That is what we talked about here and will talk about. And I should mention, Caroline Plaum told me, that it's important to think outside the box. We are not omniscient in aviation, but we have a lot of experience with the human factor, safety and training. That is the connection to aviation, but also aviation can learn a lot from medicine. So I think it's a very good collaboration. I show you just overview and objectives for our curriculum. More patient safety requires a change in perspective. We talked about here today about this. Shifting from reactive responses to errors towards a proactive, solution-oriented approach to managing risk in all professional groups, Training with a focus on this change in perspectives enables individuals to realign their outlook and cultivate an altered mindset for their own work. We heard about that. Training of multipliers. We need experts who train healthcare professionals for establishing aspects of patient safety with concrete measures in their own working environment. Our intentions is, as we all, reduce and avoid errors in healthcare, identify and assess risks, establish preventive measures, and establish a safety culture in medicine that has to grow up. Lufthansa says safety first since nearly 50 years. And they told me, we have safety on our DNA. That is what we want to reach to in medicine. Our target groups are individuals responsible for quality risk damage and crisis management in hospitals and other healthcare facilities, leaders and aspiring leaders in medical or nursing patient care from whom safety and a systemic perspective are important. Healthcare professionals seeking practical insights into the safety relevance of human factors, and of course, patient safety officers. And we have also economic employees and administration employees in the target groups, and it was very good. Training focuses not only on technical and procedural, but also interpersonal skills. That is the message we got from aviation. All three. And in medicine, we have middle good procedural and technical trainings, but we are not used to interpersonal training. And interpersonal training becomes much more important in aviation now, even in the cross-checks they make, and if they are not good in interpersonal skills, they may not fly. You see, in recent decades, medicine, emergency care has focused heavily on technical and procedural skills. Also, the majority of all problems clearly lie in the interpersonal area. You heard about this today a lot. Interpersonal skills must therefore also be the focus for the optimal treatment of patients. And that is the importance to talk with aviation or other high reliability organizations. Measures that have increased safety in aviation. For the curriculum, we took most focus on human factor and human factor training, but also in reporting and learning through reports like SIRS or M&M conferences or something like that. Then culture. The aim is to have safety on your DNA. Safety first also in medicine. and training. And it was a very good experience to have training with Lufthansa's the aviation training centers with simulators for the cabin crew and also for the cockpit crew. And the participants had a good chance to train like aviation trains. So we made a curriculum for the first step with 6 ECTS. That's not the master program, but it's a certificate from the TÜM. And the overview shows you we have 9 days in attendance. And the first is the introduction. You have it on your program in European Patient Safety Foundation 2. Then we have the learning from HRO. That is what we're talking about. And then managing our change in our own organization. And through the time between the attendance blocks, we had online-based learning. I just show you a little bit about the attendance blocks, safety medicine, creating awareness. You have it also in European patient safety, learning from others. It is very important to learn from other safety cultures and international healthcare, to learn from others, from other industries, as we also had other industries looked at, and safety culture in your own organization. Of course, we had an introduction in the context of our complex healthcare system, not only in Germany, but in Europe and in worldwide, and an excursus to measuring safety and quality, and also the medical legal perspective, because we need that when we have harm in medical care. The second block was on the airport training center, and they learned how workers from aviation are trained and about human factors, then safety in aviation, and a lot of trainings in developing psychological safe teams. And we had simulation trainings also in the cockpit as in the cabin training simulator. And then there were exercises to transfer to the healthcare sector. The last 3 days, we had the focus on initiating changes in the organization, intensify and apply a new perspective, developing a safety strategy, understanding and applying new perspectives, identifying and assessing risk. And we had also a training on the risk management process, learning about solutions and measures. We had a lot of best practices like medication safety, avoiding infections, processes in the clinical process, and they liked it very much. And we had a workshop, innovation workshop, on the last day, where the participants could collect the information they got in the whole course to have the idea what they want to make in their own organization and how. And it was very astonishing how good the results were from all the participants. We had not many, but we had 32 participants educated now. And we had physicians and nursing on the focus, but also qualitative risk management employees, executive leadership from the hospital, controlling, pharmacy, legal department, hospital hygiene, clinic manager, and hospital administration. It was really very good that they became a networking and became understanding each other. The course 23 was postponed because of the crisis we have now. We have no personnel, we have no money, and we have challenges in the crisis. So it should be the other way around. We should have the trainings because we have the crisis, but this was the argumentations. The costs are high, the cost price for the organizer is this about, and we had support up to now, and for 2023 we couldn't get it because there's no money in the budget at the moment. We had an evaluation directly after the courses, and the positive comments were various healthcare sectors, valuable interdisciplinary and interprofessional exchange, safety strategy from a corporate perspective, best practices, broadening and changing perspectives, that is what we want, and a workshop with individual projects. The critical comment was there were many professionals with a very high workload, and they didn't like the e-learning, learning diaries, logbooks and tasks, and demanding to make their own literal study. Bin ich zu spät? Yeah, okay, then it's good. The certificate in patient safety is an absolute enrichment and fills a gap that has not been covered in this way before. Personally, the certificate has enriched me immensely and significantly improved my knowledge about this subject. That is a comment from a participant, and lessons learned are the team makes a difference. The human makes the system flexible and resilient. That's why interpersonal competences have such great impact on our daily changes. That is from Lufthansa. Humans are what make the system flexible and resilient. In other words, the best automation and technology is useless if people don't know what to do when the automation fails, or don't know what the automation and technology can be used for. Motivated employees who identify with the company, the job, and the team have a significant influence on the systems. We had a second follow-up, and you see here, I can't read it here. Training of multipliers in patient safety was successful and sustainable, as the last was 1 year ago. We had a broad understanding of patient safety, a systemic vision of change, a shared responsibility, a personal experience in human factors, and the collaborating and networking. And you see a lot of people had their only safety projects and also education activities. That is what we wanted to reach. The course meets expectations and interests of the participants. Change in awareness of importance of human factors can be achieved, motivates the participants to initiate own patient safety projects. The lack of resources and financing stay a current problem, and we have to talk about this. I think that's the most important thing. And we have learned from aviation that safety must be an essential part in the business model of each hospital. Safety in medicine must be political priority in healthcare, must be part of research and education, needs the necessary financial support. And requirements and processes are changing much faster. Complexity in medicine is increasing exponentially. Experts are required extensively. We need experts, and we need experts who function as multipliers. The education of safety experts in collaboration with experienced HROs like aviation is highly recommended. And we should never give up, and I hope we have got a big drive from European Patient Safety Foundation to make it self-evident that safety in medicine is necessary. And it becomes a part of our DNA. We should go from the passive to the active and developing initiatives and own projects. European Patient Safety Foundation should act as a force of change. What can make things happen at national level, but also at European level. And we should not think about the budget because of the actual crisis. Projects are stopped and financial support is stopped and education is postponed, but we should invest because of the actual crises. It should be the other way around.
Thank you so much for this great insight into the course, which is very challenging. The only limit I see is the cost, the cost side.
Yes, but it's the third cost.
Yes.
This is the problem. We had to support.
People have to pay for themselves, you know. We don't have money in the system. This is different from aviation, even though I think the link to aviation is great that you did this. But if you think about the damages from aviation for people and from medicine, you'll see that's very unbalanced, you know. We had a crash in Tenerife, as the captain of the safety program in aviation told us from Lufthansa, that was brought into the system after the crash of 2 jumbo jets in Tenerife. And now it's recorded, it's put into Britain that they have to implement safety. Why shouldn't that be possible for medicine, I believe? Okay, can we now have a short panel discussion provided? No, yeah, 3. I introduced Dr. Michael Walker as well. Good to see you. Yeah, I know. You are sitting here for Dr.
You need a microphone all the while.
Danke. Okay, we are talking about implementation. I don't want to go into the details of your talk now at first, but I would just want to know from each of you, what is the most complex issue for implementation or limitation for implementation? Can you even talk about this?
Yeah, definitely. I'm happy to answer this. I think the complexity is very high because of the resources we don't have. So resources in terms of location. So when you think about training, you need a room, if you do it inside, you need 3 beds where you can do trainings, for example. Also staff resources. You need to have special time to implement these different trainings or education, patient safety documentation, where the time is already very busy without all these things.
Because this is not taken into account to the normal work shift, you know.
Yes, I think everybody who's working in hospital is already working much more than he or she should already. So if we need to do more,
overload,
it's getting complex. So we need to rethink a little bit the structures we have and rethink if we can get rid of something else to have more time and more resources for this.
And this in times where personal staff is going down in terms of number. Dr. Hecker, what's your opinion?
I think we have a lot of projects which are running through our hospitals and which maybe could improve patient safety. But the big problem is sustainability, Nachhaltigkeit.
Sustainability,
Because we have some behavior. We are used to do some things in some ways, and then there's a project and tries to change our behavior.
Sure. We have heard about this as to...
A few months later, we are back to the old behavior.
Right.
So that's a big problem for implementation.
That's a human problem on a global level. Dr. Ivani, you have any thoughts about this? Limitations for implementation? Does it work?
I think patient safety and safety in healthcare is a human right. And we should handle it like this, and it should not be a business model. We don't like that, but we have, and at the moment we have not the other chance, but it should be self-evident that education is implemented in all professionals in healthcare.
Okay.
And we have to address it to the politicians, to the educations, to the universities, to science and to research.
Okay. We have heard a lot of talks about culture, about behavior, science and so on, and all about the staff members and the resources in the hospital. My question is, I'm thinking about what is the role of the patient in patient safety? Any idea?
They can have a big role because they can look on their own safety. Maybe we can educate patients to look for their own safety. We have heard about the patient safety checklist. And I think patients may be able to look for never events, and maybe we can prepare them so some never events doesn't exist, or they become harmed by never events. Something like that. It's a big role to educate patients for health literacy. So we are on the topic to educate them from school.
No problem. This is a multidimensional problem, you know, and everybody looks at the elephant from a different angle and perspective, and that makes it very difficult for patients as well. And maybe my last question would be, how do we deal with the big cultural differences which are growing up right now in all countries, with all the people wandering and moving around Europe from different religious, social cultures and backgrounds? How do we deal with this in terms of patient safety? Any idea about this, please?
It's a tough question. I think we need much more education about different cultures, and we don't have that at the moment. And for the patients themselves, so when I see a patient is coming to the outpatients clinic, for example, and the patient is not able to or has another language, and you can't really talk to him, that's a major patient safety issue. So we should use technology here also, like video translation tools or any other translational tools who are helping us to more effectively communicate with the patients, and that is one part of it.
Maybe this will also be a role for AI then in this context. Do you have any remark? You? No. Yeah?
As a nurse, I would like to say that we should start teaching our children from a very young age about public health and about patient safety. This is the only way to change the mindset.
You're talking about children now, no?
Yes, I talk about young children in school. Why do we wash our hands? Why, I'm sorry, we don't spit around? Why this, why that? This is, and we saw what happened with the pandemic. The misinformation around, everybody was an expert. And we cannot exactly change the mindset from somebody who is, I'm 46. I mean, but if we start early and we also teach with a way that, you see, we're all humans and we all die the same way. I'm sorry, it doesn't matter the language or the religion or anything. I saw many people dying. Rich, poor, it doesn't really matter. And this is very, very important to teach to our children with our behavior, not with words. My children will see what I do, not what I say. And, well, I'm sorry, I couldn't keep my mouth.
You are very right. You know, we have to even not only to think about cross the links or cross the disciplines, but also start with education in children, you know. So they know what we, if they're getting elder or going to the hospital, what we are thinking about. This is a very complex task, and I think we will have many, many more congresses and discussions about this. Thank you very much for all for being here, for induction.